So we looked at symptoms of cystitis and pyelonephritis. We analyzed the results of urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis. We also recommended effective drug therapy for treatment of cystitis and pyelonephritis. Now, the next learning objective is change empiric therapy to pathogen-directed therapy based on urine cultures and susceptibility results. The concept of collateral damage refers to unintended ecological adverse effects of antibiotic therapies. And this includes selection of drug-resistant organisms, as well as unwanted development of colonization or even infection with multi-drug resistant organisms. Here's how selective pressure works. The normal flora includes a diverse population of bacteria, and this diversity is beneficial for health because these organisms can actually compete with pathogenic bacteria for growth. So they actually prohibit the growth of pathogens. Although these bacteria are beneficial for health, some of them could actually include genes for resistance. So imagine these two strains of bacteria that are pink, they actually include genes for resistance. Although they are resistant to antibiotics, they are not really causing any infection or any problems in the host. Now imagine that you start using antibiotics for an infection. While the antibiotic is important for killing the infection, the antibiotic can also kill all these beneficial flora. And when it happens, all the flora that are susceptible to the antibiotic will die, except those beneficial bacteria that were resistant. And because those resistant bacteria, although they are not causing any problem, because they stay around, they actually become the dominant species as part of the flora. And now, the majority of the flora include genes for resistance. And then when the day comes when an actual pathogen invades the host and causes infection, these flora can actually transfer those resistant genes to the pathogenic bacteria from plasmids and cause infections that are resistant to antibiotic. And this is referred to as selective pressure, where the resistant organism becomes the dominant species. This selective pressure is greatest with broadest antibiotics, and the risk is lowest with narrowest antibiotics. So therefore, it is important to keep that in mind, and when we select antimicrobial agents for our patients, to choose the narrowest possible option. This chart here is one way of thinking of broad versus narrow spectrum of activity. And this broad versus narrow is specifically based on the propensity of these antibiotics to cause collateral damage. So tier 1, which is the narrowest antibiotics, includes the urinary agents, so nitrofurantoin and fosfomycin. Because they primarily go into the urine and they don't go anywhere else in the body, they don't have the propensity to cause collateral damage. So for example, they do not affect the normal flora in the gut. The same is true with penicillin, because penicillin does not have activity against most organisms. Tier 2 includes first generation cephalosporins such as cefazolin. It also includes ampicillin and trimethoprim sulfamethoxazole or Bactrim. So tier 2 is more likely to cause collateral damage compared to tier 1. Now tier 3 includes third generation cephalosporins, ceftriaxone, as well as antibiotics that cover anaerobic organisms such as ampicillin, sulbactam, and amoxicillin clavulanic acid. So tier 3 is more likely to cause collateral damage and infections due to Clostridioides difficile compared to tier 2 and tier 1. And tier 4, which includes ertapenem. Ertapenem is a carbapenem that's actually the narrowest carbapenem available, and it's typically reserved for ESBL infections. Now, starting at tier 5, these are very broad antibiotics because now tier 5 actually has activity against Pseudomonas. So really tier 5 is when people start to talk about broad spectrum antibiotics. So cefepime, ceftazidime, piperacillin, tazobactam, ciprofloxacin, levofloxacin, gentamicin, and tobramycin, they all have activities against Pseudomonas. So these should be reserved for infections where you suspect Pseudomonas. So if you are not treating or if you are not suspecting Pseudomonas, you should not be using tier 5 and higher, because the propensity for collateral damage and selecting for resistance is greatest from tier 5 up. Now, tier 6, which includes carbapenems such as meropenem, as well as ceftolozane tazobactam. These are active against multi-drug resistant pseudomonas, so they should be reserved for multi-drug resistant pseudomonas. Meropenem is also used for ESBL producing Enterobacteriaceae, as well as ertapenem, because ertapenem and meropenem are carbapenems, and carbapenems are typically drugs of choice for ESBL producing Enterobacteriaceae. And of course, the last tier, which is the broadest, it's actually agents that are active against carbapenem resistant Enterobacteriaceae. So when carbapenems don't work, these are the options. So these should be reserved as a last resort. Another thing to keep in mind when selecting agents for treating urinary tract infection is penetration to the site of infection. Nitrofurantoin and oral phosphomycin are excellent for cystitis. However, neither of them stay in the renal tissue. So they go straight into the bladder. They don't. So they go completely into the bladder. They don't stay in the renal tissue. So therefore, nitrofurantoin and phosphomycin, specifically oral phosphomycin, should not be used for pyelonephritis. Moxifloxacin also does not go into the bladder, so moxifloxacin should not be used for cystitis. In this table, I'm showing you the percentage of different antibiotics that actually get excreted renally, as well as some antifungals. What I want you to know from this table are the bolded agents, and not necessarily the percentage, but the fact that these bolded agents get enough concentration in the urine.
So let's take a look at the case study. So let's say CR is a 50-year-old woman with no significant past medical history and no known drug allergies, who is being treated empirically for pyelonephritis with ceftriaxone 1 gram IV every 24 hours. So let's say today is day 4 of treatment, and she's clinically well. Here's the results of the urine culture. So the organism is E. coli, and the susceptibility results have come back. So basically, R means resistant. So amoxicillin clavulanic acid is resistant. Ampicillin sulbactam is resistant. Cefpodoxime is susceptible. Ceftriaxone is susceptible. Ciprofloxacin is resistant, and trimsulfa is susceptible. So what would you use? So far it's been ceftriaxone. Ceftriaxone is IV, and at some point, if the patient is ready to go home, we can change this to PO. So ceftriaxone only is available as IV. So but first of all, you want something that's susceptible. You don't want to use something that's resistant. So augmentin, for example, is PO, but because it's resistant, we're not going to be able to use it. So from the things that are susceptible, trimsulfa is available PO, and so is cefpodoxime. Cefpodoxime is a third-generation cephalosporin that's available as PO, so you have two options left. So between the two, the correct answer would be Bactrim, because PO beta lactams don't get enough concentration in the urine. So if you do have options, PO beta lactams should be your last option. So for example, if this patient happened to have sulfa allergy, then trimsulfa would not be an option, and then you can use cefpodoxime. But since this patient does not have sulfa allergy, we would go ahead and choose Bactrim, or trimsulfa would be the best option.